Yeah, Ronald, it started.
Good evening, everyone. And once again, a very warm welcome to iTrust webinars. 20 years of innovation, 20 years of trust. Once again, we bring to you the iTrust webinar, which covers the wide facets of diabetes management, insulins, and how we can look into the science of providing better care to the patients for a good outcome. I'm Dr. Kunal Shrivastava from Medical Affairs. I welcome all the esteemed delegates to this webinar. And today, what we are going to talk about is a very interesting topic, right regime for initiation, and that to choosing a patient-centric insulin regimen. We know insulin has stayed at the mainstay of management of patient. Yes, newer drugs have come, but insulin has completed 100 years, and yet it still keeps going on strong. And we have seen so many insulins coming into the market. Started with animal insulin, then human insulin, then the analogs, the long-acting, short-acting, ultra-long-acting, ultra-fast-acting, and so on. But along with that, we have also seen there have been barriers to accept insulin. Sometimes it has been taken as a threat. The patient take it as a threat, that if I don't do good, I will be started on insulin. Sometimes there are barriers to initiate. Sometimes there are some hiccups. Patients are worried about weight gain, hypoglycemia, and so on. And so all these things put together, we know it has been discussed so many times, but every time we discuss, every time we have a speaker who comes out with vast experience in this field, always there are some pearls of wisdom that's going to help us take a little bit more better care of the patients. And for today's webinar, it's my honor to welcome our speaker for today, Dr. R.K. Samar sir, who is a professor and HOD Medicine at Pacific Institute of Medical Sciences, Umrada, Udaipur, Rajasthan. Is a senior consultant physician, diabetologist, and cardiologist. What sir brings with him is more than 4 decades of experience in his field of cardio-diabetes. Sir has been invited speaker at various national and regional conferences. There has been advisor at various advisory boards of the pharmaceutical industry. He is a member of IMA, API, RSSDI, All India Endocrine Society, All India Rheumatology Association.
Attendance, full attendance list.
Not only this, he has several publications to his credit, and he has been investigator in many phases. So with this, I invite Dr. R.K. Samar sir for his topic for today, right regime for initiation, choosing patient-centric insulin regime. With this, I'll hand over the stage to sir. Sir, you are most welcome. You may please start your oration.
Participate 105.
Samar sir, if you can hear us.
Okay.
जीरो क्या है? वाटर टैंक आपने चलो ये दो तो
Samar sir, we would request you if you can just unmute, switch on your camera, and we can start with the topic. I think, sir, you have joined from two devices.
Hello.
Hello. Yes, sir. We can hear you, sir.
Okay. So now we can start.
Sure, sir. I request everyone else to kindly put yourself on mute other than the speaker. Over to you, sir.
Okay. Welcome to all of my colleagues and seniors. Today, on this series of iTrust, I am going to speak choosing a patient-centric insulin regime. Next slide, please. So, why should insulin be adopted more? Why we want that patient of diabetes should have more and more insulin? So this paragraph or this graph shows that if a person is having it means oral anti-glycemic drugs, there is a reduction by 1% in sense of hemoglobin A1C. If we use 3-OAD, there is a further 0.5% reduction. And then if 4-OAD, if we start, even then there is not much effect, rather it may slightly increase. And if we use insulin, there is a reduction by 1.3% in post-treatment assessment. So use of multiple OADs driven by convenience, acceptance by patient, and limited consultation time is required. So right approach in early diabetes patient. But success of OADs provide lessening effect, sustained benefit from initiating insulin, the mean hemoglobin A1C, as I already mentioned, that there is a decrease by 1.34%. Longer complication, free survival. Unlike insulin, addition of subsequent oral anti-diabetic drug doesn't offer benefit. Next, please. So, in spite of progression of diabetes, over several decades, insulin is ignored vis-a-vis OADs. The prescription pattern of anti-diabetic drug across duration of diabetes in India, if we see for the patient having diabetes from 5 years, 0 to 5 years, only 98.12% are using OAD, and insulin is used in 1.87%. Further, if we see 5 to 10 years, the insulin is again it is very less used, 6.86. At 10 to 15 years, 25% people are taking insulin, but at 15 to 20 years, 26.31% are taking insulin, while at the more than 20, where we suspect more and more insulin deficiency, the only about 50% of patients are taking insulin. So there is is because as we know that with the time insulin deficiency is increasing, but still we are not optimally using insulin preparation either by patient point of view or physician point of view. So what we can do, let us discuss. Thank you. Next slide, please. So this is a very good paragraph graph showing that type 2 diabetes, there is a decline of beta cell function and insulin secretion. So with the time, we know that diabetes develops metabolically 12 years before it clinically manifests as a diabetes. And as the time passes, the insulin deficiency decreases, and one time comes when insulin secretion is zero, or we can say beta cell function failure is there. That is primary failure. So at that time, definitely there is no option, insulin is required. But as we are seeing that if we start insulin early in a proper way and proper indication, the chances of micro and macrovascular complications are reduced, where that has been approved in DCCT trial and UKPDS. Next, please. So with inevitable progression of diabetes, a therapy providing best in class hemoglobin A1C reduction would be play a major role. So various drugs, oral hypoglycemics has been mentioned here, and we can say even GLP-1 receptor antagonist, there is a less 1.12% reduction, DPP 4.7%, AGI 0.72%, this glitazones 0.96%, sulfonylurea 0.77%, glenide 0.64%, metformin 1.21%. But if we see the various preparation of major insulin, they are definitely having more reduction. Say for example, basal 1.28%, then biphasic insulin 1.91%, prandial 1.08%, basal bolus is 1.22%. So achievable hemoglobin A1 reduction is there in case of insulin. Even newer drug SGLT2 inhibitor also reduce the blood sugar in sense of hemoglobin A1C only by 0.74%. So definitely insulin is superior to control effectively and emphatically without hypoglycemia in every patient of diabetes if it is started early. Next, please. So what do we want from insulin therapy? Number one, a complete glycemic control missed by OADs, which prevents or lowers the risk of future diabetic complications with lesser side effects such as hypoglycemia and weight gain, with convenient and minimal injection burden. So newer insulin offers minimal risk of hypoglycemia, as we know, and new generation devices offers virtual painless injections, simple to inject and the dose and titrate as needed. Next, please. So, right regime for initiation of insulin. Let us discuss choosing a patient-centric insulin regime. The choose basal insulin for initiation. That if we take the glycemic factor, what are the glycemic factor? If postprandial postprandial increment is less than 18 milligram per dl, if fasting and hemoglobin A1 ratio is more than 20, or and morning blood sugar is less than for 55 milligram, consider basal initiation and optimization. Psychological factor, if patient has a limited literacy and simple and easy to understand the regime is needed for insulin initiation. If open to switch to different insulin regime with progressing the diabetes. So we indirectly we are breaking the insulin inertia in a patient if we give it in a proper way or at proper time. Phase of life, where it can be used. If a patient is child, use basal bolus therapy. If patient is an adult one with an easy stage of disease, early stage of the disease. If patient is pregnant, use basal bolus therapy. If patient consumes lesser carbohydrate in the diet, if insulin is initiated early in the disease stage, with minimum diabetes complication and comorbidities. A patient is willing for time intensification of insulin therapy to different regimes when basal insulin alone is insufficient. So these are all patient realities and Indian realities where we can use the insulin properly. Next, please. Next, please. So key clinical consideration to initiate the insulin is that what should be the starting dose? At what time of the day should insulin be administered? How to relate it with the meal intake? Then which device to choose? How to inject it and how to adjust the dose of insulin that we will be discussing. Next, please. So there are various preparation of insulin and we label them as a bolus, premix, and co-formulations. So bolus therapy, we know that now newer insulins are available. So regular human insulin and insulin glucose, insulin lispro, aspart, and now we are also having faster aspart. So all of them generally recommended in 4 units to be started. Time for administration and related to meal, we know that human insulin R is generally started 30 minutes before meal, and it is indicated in pediatric group and uh, uh, gestational diabetes patient which have a class B indication. Then 4 units are of the all other preparations that can be used in immediately before or soon after the meal, except in case of faster acting insulin, where it can be administered 2 minutes before or even 20 minutes after the start of meal. So, in pediatric group, from 2 years to 1 year, these preparations can be used as it mentioned. And class of they in the GDM, there is evidence of class B. Then premix insulin, we know that there are various preparations available biphasic immune insulin 30-70 or or 50-50, then 75-25 or 50-50 or aspartate biphasic 30-70 and 50-50. So they generally use in the strength of 6 units, premix 10 unit and 10 unit respectively. So they are generally given pre-breakfast or pre-dinner, pre-breakfast or pre-dinner, or sometimes we have to split the dose into equal breakfast and dinner. An injection should be followed within 30 minutes by meal, and that is for particularly for biphasic human insulin. Immediately before meal, if it is biphasic insulin, particularly as part, or immediately it should be followed by meal. And generally we use above 18 years of age. And in case of gestational diabetes, there is a class B indication. Then co-formulation means we can use the insulin deglutate or as part combination 10 units with the main meal above the 18 years of age, and the class is C. While if a combination, co-formulation of the this IDEC with liraglutide, 10 dose steps at any time, same time of the day, and generally it is used above 18 years. So these are the preparations which are available. I repeated that bolus, premix, and co-formulations are nowadays used in practice of insulin therapy test. Next, please. So basal intermediate acting insulin, as you are using NPH, and 10 units are given once daily or required by on requirement, it can be done shifted to twice daily dose, and it is again having class B indication, pediatric and GDM. In both the conditions it can be used. Basal long acting insulin, we know that glargine and dacmir is there, and generally it is started from 10 to 14 units, and it can be given at any time without relation with the meal. and generally they can be used about 2 years of age, but class indication is C. Then basal ultra long acting insulin, we can use insulin degludec, that is also started with 10 units. Flexibility in daily dosing, 8 to 50 hours window when needed, and it is also can be used above 1 year stage. While insulin glargine, the one routinely we are using U100, now it is available as a 300, and 10 units can be started. And again, for GDM, there is a class is C, and it is not used particularly in pediatric and GDM patient. Next, please. So, insulin intensification should follow disease progression. So, as this chart is showing very clearly that as the time passes, in a case of patient having diabetes, there is a decremental uh, effectivity of beta cell failure, and insulin secretion becomes less. So, initiate with the full dose, required dose, and if you can also follow with lifestyle and OIDs, and then basal insulin is added, and some people prefer premixed insulin with OIDs. But as time passes, we have to optimize the dose, titrate dose to reach maintain glycemic target. And further, as time passes, the basal and 1 to 2 4 bolus injection before meal can be used. Or some people use premixed insulin with or without OADs. So as the time passes, we have to initiate, optimize, and intensify the dose. So intensification for additional mealtime coverage is may be required later on. Next, please. So intensification of basal insulin is recommended if patient is unable to achieve hemoglobin A1 target with 0.5 unit per kg per day of the basal insulin, or hemoglobin A1C goal despite normal fasting with basal insulin. So targeted PPG level persistently above the goal with basal insulin. So in all these three conditions, patient may require intensification of basal insulin doses. Next, please. So advice and follow-up of these patients is at the time of initiation, benefit of insulin for people with type 2 diabetes. The injection technique should be explained to the patient, including when to take, how much, sharp disposables should be kept in the mind. First injection should be in the clinic, and patient should be provided with simple and straightforward instruction to inject at home. Second, discuss the possible hypoglycemia and weight gain and how to tackle if it occurs. Daily management is injections. This is self monitoring of blood glucose. Targets, we should know that how much target that is decided by clinician for the patient, and titration and when to call the patient for follow-up. Timely proactive follow-up in critical success factor and can be fulfilled by healthcare practitioner or other members. Follow-up visit after insulin is started may vary from as soon as 1 day to 2 weeks. So at most, first follow-up visit, what we should discuss, the concern about the insulin, issues with the review SMBG logbook, injection technique, begin and continue titration, and these American Association Diabetes educators self-care behavior should be advised. That is healthy eating, physical activity. Patient should be explained. Medication taking should be explained. Monitoring of the blood sugar and other factors. Risk reductions, healthy coping and problem solving. All these should be discussed with the patient. Next, please. So guideline recommendation, that is insulin initiation by RSSDI or ESI consensus 2020, break treatment inertia and have timely insulin initiation for better glycemic control. Insulin therapy should be considered in all patients failing to achieve glycemic target on 3 oral agent. So here there is no option. We have to, if a person has reached to 3 optimal dosage of oral agent and not controlled, the option only remains to start insulin. A 3-step protocol involving initiation, titration, and intensification, as I have explained, is recommended for all patients requiring insulin. Insulin initiation, that is, initiate with once daily basal insulin or once daily premix or co-formulation insulin or twice daily premix insulin, either alone or in combination with other OADs, that is based upon patient age, clinical feature, glucose profile, risk of hypoglycemia, and patient preference. Basal bolus insulin regimes may be needed in several hyperglycemia and in the life-threatening or organ limb-threatening clinical situation. These are all emergency. Here we have to no option. We have to give basal bolus insulin therapy. That is the insulin before the meal and basal at once or twice a day. Next, please. So insulin at diagnosis, in case of symptomatic hyperglycemia, organ dysfunction, metabolic decompensation, and ongoing catabolism, that is weight loss, all they indicate that insulin should be started. If symptoms of hyperglycemia are present, or when the hemoglobin A1C is more than 10%, or blood glucose levels are high, more than 300 milligram per day, planning pregnancy, and also one should not forget that glucotoxicity and lipotoxicity, it should be tackled immediately by insulin. Next, please. So recommendation for concomitant use of OADs in patient taking insulin, that is metformin, continue using with insulin. There is no contraindication of combining these drugs. Then sulfonylurea, initiation of basal insulin in OD form, modern sulfonylurea may be continued with appropriate precautions. Then initiation of pre-mix insulin, modern sulfonylurea may be continued at the antipodal wheel. Then initiation of premix insulin BID, short-acting sulfonylurea may be continued or added to the third wheel with appropriate glucose monitoring. So, keeping a precautions and keeping an eye on hypoglycemia or weight, we can add sulfonylurea to a insulin therapy. Then glitazones can be used with insulin that will reduce the dose of TGD by 50%. Discontinue if the symptoms of cardiac failure are present or there is a history of edema. Then AGIs, it can be safely used with basal and premix insulin. DPP-4 inhibitor can be used with insulin if GLP-1 receptor antagonist is not taken by the patient. Then SGLT2 inhibitor can be used with insulin for better control, could be considered in addition to insulin in patient with type 2 diabetes and establish SCVD or the atherosclerotic or indicators of high atherosclerotic changes or risk like coronary artery disease, cerebrovascular accident, or peripheral vascular disease. Then it may help to reduce the insulin doses. So next, please. So limited care recommendation for frequency and timing of SMPG, type 2 diabetes mellitus on insulin plus OADs, new onset diabetes, uncontrolled diabetes, diabetes during acute illness, at least fasting blood sugar, and one more pre-prandial values every day should be taken. Must check whenever hypoglycemia is suspected. Then stable and well-controlled diabetes, at least one value on alternate days at different time of the day with at least one fasting blood sugar every week. Must check whenever hypoglycemia is suspected. So SMBG, that is self-monitoring blood glucose, which provides the day-to-day blood glucose level, is a simple and practical tool for maintaining good glycemic control. Next, please. So timely insulinization is required. How do we optimize the adoption of insulin to improve the status of diabetes care in India? Next, please. So, what is the reason for therapeutic inertia in a insulin therapy? We are talking in the sense of Indian practice. So, physician factor, that is physician inertia leading to therapeutic inertia for insulin therapy. Patient fear leading to patient factors leading to therapeutic inertia for insulin therapy. So, in the inertia is from both the sides, from the physician side and patient side, and how to resolve it. Let us discuss. Next, please. So, physician factor leading to therapeutic inertia, what are the causes? The perception and inaccuracy in healthcare practitioner assessment of patient preferences, concern, and self-management skill. So, they don't evaluate properly to the patient that is done at the level of healthcare practitioners. So, perceived patient resistance to insulin therapy, physician overestimation of injection fear among the patient, concern about the adherence, perceiving many patients are unable or unwilling to adopt to a more complex treatment, perceived lack of diabetes self-management skill on the part of patient, the perception regarding patient prior non-adherence to oral agent is insufficient, perceived healthy literacy problem of the patient. So insufficient time, lack of healthcare practitioner knowledge and experience about insulin therapy and language barriers are there in inertia at the peripheral side. So 4T's should be kept in mind: lack of training, lack of time, fewer tools for monitoring, lack of team. So all these can lead to less use of insulin at the periphery level where it is required, as I have mentioned. Next, please. So patient factor leading to therapeutic inertia for insulin therapy. There are many misconceptions. Number one is the lack of self-confidence in their ability and motivation to perform diabetes self-care tasks. Distress, feeling that one is failing at diabetes management tasks. Optionizing reviews, patients often have a goal of reducing or eliminating medication, unlike healthcare practitioners who feel intensification is necessary. And there may be, as the number of insulin is doses are increased and various preparations are given, there will be financial burden. So social stigma and fear of injections are also a factor at the patient point of view. Then, if I give the examples, insulin therapy represents worsening health condition that is a thought in the patient mind. It's a punishment for having failed at diabetes control, unrealistic fear of side effects such as weight gain and hypoglycemia. Insulin causes harm, that is blindness or amputation. The above misconception and realistic concern lead to phenomena often referred as psychological insulin resistance in people with diabetes type 2. Next, please. So, overcoming social and psychological resistance of insulin therapy, possible solution what we can do at the level of practitioner or at the level of patient. So at the level of practitioner, begin discussion in a collaborative communication style, discuss the health benefit of treatment target rather than threatening the patient about the complication. Explain that treatment changes are a normal part of living with diabetes and not a sign of personal failure. Explain benefit of insulin therapy, that it is eventually required in most cases. Addressing injection concern by demonstrating a actual injection process. That's why first injection should be given in hospital, and mostly the doctor should guide the patient and encourage the patient to take this injection self. Assess and address the patient concern and belief about the insulin. So the above key health factor which I have explained to a practitioner action are linked with earlier insulin initiation and greater insulin persistence over the time. Now what can be done at the patient point of view, knowing that some care and effort, long and healthy life with diabetes is possible. Learn early on about how type 2 diabetes changes over time and how the need for additional medication and treatment is not a sign of failure or an indication that diabetes is worse, but rather a logical and necessary means of addressing the normal decline in pancreatic function associated with diabetes. Addressing concern about the diabetes and insulin therapy, then viewing the SCP as being on the same side can facilitate a trusting relationship. So good sympathetic contact between the patient and a practitioner will play a major role. So focused appointment such as designated diabetes visit to minimize competing demands. Next, please. So how to facilitate insulin adoption and improve status of care in India? So we have discussed in detail, educate and train the physician, effective patient education, bridging the gap, improving the adherence, leveraging paramedics like nurses, educator to support the or amplify the doctors' capacity, increase treatment capacity by leveraging PSCs and other available infrastructure, supplementary support of technology. So adoption of simple, easy to explain, yet effective treatment option in limited consultation time. Next, please. So we have discussed about the insulin as our discussion and as we have read from these slides that insulin is a first drug to be started in case of diabetes, and but if it use insulin in a proper way, proper dosage, and ultimately we will get less complication, both microvascular and macrovascular complication, which various studies have shown, like DCCT and UKPDS. So friends, I have tried to explain about the insulin, when it should be started, how the dosage should be given, and inertia of the physician and inertia of the patient should be reduced by with various methods which I have explained. Thank you very much for giving me this time to explain you about the initiation of insulin. If any queries, I will be able to give you answer. Thank you, sir.
Thank you so much, sir, for such an interesting and in-depth oration, where you actually tackled all the real-time in-clinic challenges that are there, the inertia and how to tackle that inertia. Meanwhile, the floor is open for question. If you have any questions, you can post it on chat box. Sir, by the time we are getting questions, I have a few questions of my own, if you'll allow me.
Sure.
Sir,
Sure.
Thank you, sir. So, sir, we discussed about insulin initiation and as it should be initiated early. Now, my question to you, in your routine clinical practice, when is it that you initiate insulin and what is your go-to insulin? I mean, with which insulin you usually initiate treatment and why?
So there are many factors. If we diagnose the patient of diabetes at first time, then we have to see why the patient has come to me. What are the complaints of the patient? Number one. Number two, what are his blood sugars, various parameters, fasting, PP, pre-meal, post-meal, and what is his hemoglobin A1C. As I have explained, if the hemoglobin A1C is more than 10 and the patient blood sugar is 300 and more than that, then our moral duty is that we should control the blood sugar to reduce the glucotoxicity and lipotoxicity. Number one. Number two, we know that if we control the blood sugar promptly, there will be long run less chances of developing micro and macrovascular complication, particularly microvascular complication, which we know that by DCCT trial and UKPDS trial we have come to know. So our aim is that we should control the blood sugar, but at first instance, if we say to the patient that you have to take the insulin, we may discuss with the patient, and we may say to the patient that if you want to continue it for right from beginning, you can. And if he still is reluctant, then at least we should control blood sugar initially. Then we can keep the patient on oral hypoglycemia. And a second indication is that if a person is even oral hypoglycemic drug, uh, more there is less advantage, more using oral hypoglycemic drug, then there is no option. You have to air the insulin.
Thank you for that answer, sir. And definitely, sir, it is as the topic itself says, it's a patient-centric approach. So definitely, all the factors that has to be looked into while initiating insulin. Sir, just one last question. We saw a very elaborate list of all the various insulin preparation those are present over there, and with a specific focus on a pediatric population and GDM. So how does that decision work when we are trying to initiate in that population, in pediatric population or in GDM?
So first question is the diabetes in pediatric population. We mostly we know that pediatric population, they are having type 1 diabetes, and type 1 diabetes, we know that it is an autoimmune type of diabetes. There is a destruction of the beta cells, and there is a immediate deficiency of insulin. Rather than this, they develop abruptly. They develop total insulin deficiency, and if insulin is not there in the body, they have to be supplied by the insulin from outside. So insulin is must in a type 1 diabetes, number one. Number two, they according to blood level, which we have mentioned that our 7-8 parameters of the self-moderating blood sugar, we have to adjust the dose. So basal bolus therapy is the option for a pediatric patient. And for regarding gestational diabetes, the studies are on insulin, and insulin, particularly insulin, it should be given initially, and our target of controlling the blood sugar must be achieved. And some people off-label use metformin and glimepiride, but they are internationally not recommended. So insulin must be given to a patient of gestational diabetes to prevent the complication in mother as well as in the fetus. But there is no strong indication. The indication is at the level of B. The evidence is B level.
Thank you so much, sir. And definitely, it was really enlightening and very informative oration today. And yes, the in-clinic and handling the perception and the psychology of the patient is the cornerstone when we are talking about patient-centric management of diabetes. So thank you so much, sir, for this wonderful enlightening lecture. And for the vote of thanks, I'd like to invite our marketing manager, Mr. Ninad Parekh. So, Mr. Ninad, it's over to you.
Thank you, Mr. Kunal, Dr. Kunal, and thank you once again, Dr. R.K. Samasa. So it's thanks once again. And now I have to close the sessions with the vote of thanks for thank you. So before that, I close. It's great news to all of you. We are celebrating 20 years of India's first biosimilar insulin, Insulin. We are launched in 2003 and proudly put India in the global market. The insulin manufacturer third country after US and European country. The Insulin is the India's first biosimilar insulin, and it's developed and manufactured in our Aurangabad facilities. It's inaugurated by Mr. Dr. APJ Abdul Kalam, sir. And I thanks to all doctors and medical facilities for supporting Wusulin. And Wusulin is completed 20 years. For very much thanks for your support. And extended thanks Dr. R.K. Samar, sir, truly enlightening and informative presentations. And most thanks to all delegates taking time and join this iTrust webinar, the different part of the India. And obviously participants is as a human value. Extreme sincere thanks to Dr. Kunal for discussions and Dr. Sanket Nawale for providing scientific input. And special thanks to goes our IBB head, Mr. Amrut Medigar sir, and gratitude to Mr. LCS Vishnu sir for supporting and guidance this webinar. And also extended hearts to thanks to our all field colleagues, heroes, and HO colleagues for supporting this webinar and executed very smoothly. So thank you all teams and doctors. Thank you. Now we are signing. Thank you, sir. Thank you.
Thank you. Thank you.
Thank you, sir. Thank you, all the delegates. Have a great day ahead.